Dr. Singh, what's going on? Happy Friday. Good to see you on board.
Happy Friday.
How are you?
Good. How are you?
Good. I was went to the city for a couple hours, had a few meetings, and then I came back. You went to New York City before?
I have actually went for the first time in like 2022 for a friend's engagement. So,
Very nice.
yeah,
Did you like it?
it was nice. Yeah. I definitely want to check out upstate more at some point whenever I get a chance, but I was mostly in like Long Island area or like Brooklyn and all that stuff. So, I saw like the main touristy places and the bridge and stuff. So that was
That's
nice.
cool. That's cool. Yeah, I laugh because I'm from Brooklyn, New York, and the New York City, the island is in my backyard. So we us growing up, we would go to like Long Island, New Jersey. Want to go away from Brooklyn, right? To go to the beaches and meet
Mhm.
people, and then people from there come to Brooklyn. So it's funny. And then Long Island we used to call Strong Island just because they were a different breed of people, guys especially, right? And then you have New Jersey, and then the way it was just interesting how back then Long Island is far from here too, even though it's part of
Yeah.
Brooklyn. If you keep driving, you go to Montauk, Southampton. It could be like a 3 hour drive. So it was just funny because out there they don't come to the city often because it's very far. So they have
Mhm.
like get-togethers and parties and barbecues, whereas our backyard is New York City, so we just
You don't really
hop
have
on
a
it.
backyard
We don't have a
much.
backyards. So
Yeah.
like, all right, we can't throw a barbecue every weekend because we have no backyard. We're just gonna go to New York City and go have a good time in the city, which
Hmm.
was our routine. Yeah, it's nice. I mean, and then you have upstate New York. My parents have a house upstate New York, Monticello. So it's about like a 2.5 hour drive north of Brooklyn or New York City. And
Okay.
it's nice because it's a little bit of you have the concrete jungle of New York City, and then you have the forest up north, which is a lot of beautiful parks and just gorgeous scenery, right? Mountains and
Hmm.
green and grass. Because New York is concrete, concrete. So that's cool. That's cool. Cool. I mean, let's see what happens today. I know it's a Friday afternoon. You can't
Yeah.
really force anybody to jump on. Happy that you came on and see whoever else trickles in. So how are you? I mean, I keep asking because I care, right? So
Yeah.
how are you doing day by day? I mean, actually, hold on, give me a second. Let me. I can't unrecord this. I actually know. You know what, Dr. T on. I think that will help.
Yeah.
Numbers. We'll try, right? So cool.
Okay.
All right. Dr. T's on board. Dr. Singh's on board. I want Dr. Singh to do a couple questions if that's cool. Because I
Yeah.
mean, Dr. T you guys could do questions back and forth. I'm here twice a day, guys. Rain or shine, unless I'm sick, I'm here. Um, so GI, as you know, is a lot. Now, Dr. Singh, you know me, I could talk nonstop. What have you gathered so far from being here all the time, practicing with us about GI? Because GI is a lot from the mouth, from the oral cavity, all the way down to the anus, right? There's
Hmm.
many points there. So what have you gathered so far from our sessions that we do twice a month for GI, and also just studying in general for medicine? What's your take on that?
I think GI is like a lot to work with because I feel like majority of the questions that do get asked, it's either pathology or like anatomy related. And I feel like
Hmm.
that's where I end up scoring low on. Like
Hmm.
pathologies I can figure out and do well with. It's the anatomy that screws me over sometimes because
Okay.
there's just so much going on
Yeah.
with it. So I've been improving on that um quite a bit. So like I'm
Good.
feeling a lot better about it, but I feel like GI overall isn't that bad. And I feel like on step it's not that highly rated either. So it's like you could squeeze by if you needed to
You
with
know,
that one.
and it's true. GI, I mean, for me, guys, we're talking real now. When I was studying, no one told me this. They just said, study, 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 get everything done, right? Realistically speaking, in anatomy, for example, they can give you anatomy of the esophagus, stomach. pancreas, liver, intestines. That's a lot. Vasculature is a lot, right? So if you had to do something like that, maybe like in the pancreas head, because clearly pancreatic cancer is big, right? Or the watershed area, areas of infarction, right? Small bowel obstruction, those kind of things. But like you just said it before, GI might not be big, but think of it this way. When I push you guys hard to do micro every Wednesday, isn't for me, it's for you. Because when you have a lot of GI, it could be intertwined with GI micro, right? H. pylori, C. difficile. I mean, think of everything that is involved in the stomach, the esophagus, the intestines, right? Then you have obviously you have different connections with celiac disease, vitamin deficiencies, B12. So to add to what you said, you're right. Like realistically, it's not as high as other specialties, but you realize they can kind of twist it all around. Like cardio is big, but if you look at the statistics, it's not that highly rated on STEP. It's like, what the heck is highly rated? They have farm, path, and phys. Okay. But everything is farm, path, phys, right? That's why be careful. That's what I'm saying. Because cardio, I look at the numbers, I'm like, but then they could do cardio micro, talk about any kind of organism, talk about cardio pharmacology like Dr. Rubinson. They could talk about cardio immunology, right? So that's why I advise you all to conquer most of the systems. Just look at clinical correlations and situations. Like today, for example, we'll do a couple of questions. But when you do GI, do you know about gastric ulcers, duodenal ulcers? Do you know about the esophageal issues, right? Diseases. Do you know about small intestines, large intestines, maybe the hormones? Don't go nuts, right? Don't go crazy into anatomical structures and I gotta know the embryological derivations. Like, good luck. It's a lot, right? So look at the larger picture. And if you have AMBOSS, I promise you, go to the 200 concepts, hit them hard and expand. 200 concepts, 200 questions, guys, are 1,000 explanations. That's a lot. If you're not doing well there, that's a good sign you got to go back, right? So don't get caught up in learning everything about GI. It's too much. Cool? Yes? All right. I want to round robin with you, meaning when at tennis, it's a round robin is we just round robin. We go from one person to the next competition, right? Round, round, round. I want to do some questions with you, Dr. Singh, and then we're all here as a team, all three of us, which I'm happy because you guys, again, people are tired. It's a long week. They're working. It's all for people who could jump on or not. Let's read a couple of questions, Dr. Singh, and I'm going to warm you up. Okay, let's do it.
Okay. So physical examination shows warm edema of the left forearm with overlying erythema and a tender, palpable cord-like structure along the medial arm. His lungs are clear to auscultation bilaterally. Duplex sonography shows thrombosis of the left basilic and external jugular veins. Which of the following is the most appropriate next step to confirm underlying diagnosis? Okay, I'm gonna go to the
What do you want to do? Go to the top? Sure.
62-year-old man comes to the physician because of a 5-day history of swelling in his left leg. So maybe DVT or edema. 2 months ago, he was diagnosed with DVT in the left calf.
There it is. There you 2 months ago. There it is.
He has a 15-pound weight loss in the last 3 months. He smokes 1 pack of cigarettes daily for 25 years. Only medication is warfarin. Okay, so blood thinner.
A lot of stuff going on here, right? I mean,
yeah.
Being honest with you, we have. Well, let me ask you this because I want to jump in, but I'm always like caring and concerning. I'm always like, let me jump in. Let me ask you this. This is a great question because it's not easy, but it's challenging, but you can unravel it. You just read the whole scenario, right? You did the last 3 lines, went to the top. You're like, maybe you do, maybe you don't know. What is 1 or 2 things here that you see that actually stands out? Like, wait, this is kind of interesting. Right? Just walk me through the case. Walk me through the presentation.
So it's like with the DVT and then the swelling of his left arm, with like erythema, tenderness, palpable cord-like structure. I'm thinking there's like an emboli that probably
Okay.
shot through and went to that side.
Yeah. Because I mean, you have DVT in the left calf, right? You
Hmm.
have swelling in the left arm. So you have swelling left arm for the past 5 days. 2 months ago, you have a DVT in the left calf.
Hmm.
Then you look at it, lungs duplex of the left basilic and extra jugular veins, thrombosis. You're like, wow, okay, so
It's like
it's it's
recurrent thrombosis.
it's migratory, right? Thrombophlebitis.
Hmm.
It's kind of going everywhere, right? So
Oh yeah.
so usually in the USMLE world, again, the more questions I do and the more years I put into this, you cannot predict what's going to be on the exam. I've tried with patterns. I do know which is most tested, but still, it's still randomized. But I do know the way they present things. For example, if it's going to be like emboli, usually it's right leg going up to the lungs. If it's anything dealing from a right leg, now they stroke out. What usually is indicated? The person that has a DVT and next thing you know they stroke out. What right away? What do you think is going on?
Brain emboli.
Well,
Like
well, how think about the traveling. How would it get from the right leg to the brain? Can't.
if they had some type of like PDA or something, it could like
Yeah,
push over and then go towards the brain.
because guys, lungs catch everything. That's why you have a P, right? So a
Hmm.
P is kind of like a stroke in the brain, right? There's a clot somewhere. It's an emboli. So if you have the right lower leg and it travels up into the right side of the heart, it's going to get caught in the lungs before going to the left side. So it's impossible to get to the brain. But if there's an opening in the atrium, right, the ventricle, sure, well, yeah, there it is. Then it just kind of bypasses everything. Forget about the lungs. It goes straight into the brain circulation. You stroke out. These are the things that when we do more questions, this is why we do more questions to pick up patterns, to figure out, I've kind of seen many cases and I have an idea of how they would present these kind of things. So in this case, it's migratory thrombophlebitis, right? Okay.
Hmm.
So regardless, you need to know next step to confirm diagnosis. Let's say, for example, you couldn't pick up migratory thrombophlebitis for now. I get it because
Hmm.
they have a hypercoagulable state. Like they're clotting everywhere. Can we start knocking out answers just to kind of say, well, I can start knocking stuff out?
Yeah, so I don't think it would be the antiphospholipid. Like even though you could have clotting issues, it's usually in like women, and if you had like is it the fact not factory, it's like kind of lupus related.
Okay, okay. And also, don't forget, we also have a lot of weight loss here. So
Mhm.
as we see more of the hypercoagulable state that this person's going through, we also remember, like before we have to make sure we take into consideration all the findings that are embedded in the scenario, or else we just choose what we want and then we neglect the other stuff that's important, right? So
Mhm.
antiphospholipid, APS, usually it doesn't have weight loss and it doesn't present with this clotting that this person's presenting with. So we take that
Mhm.
out. Okay, cool, cool. What's a D-dimer level? What does this indicate here?
That would indicate DVT, and they've already had one 2 months ago, but it's not saying they had another DVT. This is
Yeah,
typically somewhere else.
exactly. It's confirmed. It's already kind of confirmed, or there's something going on. So serum
Mhm.
D-dimer level, there's a history, there's a confirmed history of DVT, which means you really don't have to do it again, right?
Yeah.
Good. So start eliminating because that's what's going to help you on some questions on exam day. I
Mhm.
promise you.
Chest x-ray, I don't think that would be it because I feel like that might be leading towards like maybe pulmonary embolism, and it's not talking about that.
Sure, sure. I mean, because look about it. His lungs are clear to auscultation. So a
Mhm.
chest X-ray, to order a chest X-ray, I mean, that's going to be if, for example, there's maybe some respiratory concerns, issues, maybe signs of lung cancer, right? I mean, that's usually you use that for risk of lung cancer. Okay. So,
Mhm.
I mean, he has smoked one pack for the past 25 years, but it doesn't warrant to do a chest X-ray to confirm the underlying diagnosis. Okay.
Right.
So we have a 24-hour EKG monitoring. We have a TEE and we have a CT